My patient's door, knock knock, and then I would go ahead, perform hand hygiene, 20 seconds per CDC. Hi, my name is Alex and I'll be your nurse today. Today I'm going to be doing a head to toe assessment. Do I have your permission to touch you? They say yes. Okay. So first I'm going to go ahead and verify the name and the date of birth of my patient. Once they verify that for me, then I'm going to go ahead and make sure that it matches with their wristband. Once I check their wristband, it matches up. Do you have any allergies, any latex or medications? They say no. Then I move on to going and gathering all my personal protective equipment and all my necessary supplies to perform my procedure. So what I would need is my stethoscope, my pen light, and also my gloves. And then with that, I'm just going to go ahead, pull the curtain for my patient privacy. So with that, then I'm going to go ahead and just in case, grab a red biohazard bag just in case I need to dispose of any soil supplies, and even after I dispose of everything, then I would also make sure to perform hand hygiene. So once that's all cleared away, then I'm going to go ahead and work on my neuro assessment. So with this, I'm going to be checking level of consciousness. So what is your name? What time is it? What brings you to the hospital? And where are you right now? If they answer correctly to all 4 of those questions, then they would be alert and oriented times 4, which meaning that they're alert and oriented times 4 to the person, place, time, and situation. So then I would go ahead and assess their overall demeanor of my patient. So whether they are, if they seem worried, if they're frantic, if they seem calm, and also check for personal hygiene. If they're well groomed, or if they're, if they're messy, if they're homeless, then their personal hygiene wouldn't be that well. And then next, I'm going to move on to assessing their communication. So assessing communication, whether or not they can articulate coherent sentences, if they have slurred speech, or if they have hearing aids, if they're having problems hearing me. And then also checking for their vision, whether or not they need glasses or if they wear contacts. So then next, I'm also going to be asking if they're in any pain today, and if they are in pain, asking them to rate their pain on a scale of 0 to 10, 0 meaning no pain, 10 meaning they're in the most crucial pain that they could be in. And if they say, my patient says no pain, alright, then I would move on to assessing for their head. But if they did say they had pain, then I would go ahead and assess PQRST. So since my patient said they had no pain, I'm going to go ahead and start inspecting their head area, and then checking for any lice, any manifestations, seeing if there's any dandruff, checking to see the skin integrity, seeing if there's any tenderness, inspecting first. And then next I'm going to be checking for the ears. So in the ears, I will be checking for any drainage, if there's any drainage in the ears, if there's any abnormalities, anything going on, and then next be checking for their face. So checking for any facial droops, checking to see if they if there's any facial droops, checking the color, if they seem to be pale, flushed, or jaundiced. And if not, then next I'm going to be inspecting for their eyes. So for their eyes, I'm going to be inspecting them by using Perla, so checking to see if their pupils are equal, round, reactive to light, and accommodation. So for that, I'm going to be looking into their eyes, seeing if their pupils are dilated or constricted. And then next, I'm going to be using my pen light, and since I don't have a patient working on, I'm going to use myself. So what I would use is my pen light going over their eye and going over their head, then checking the next eye. Alright, and then normal ranges for their pupils would be between 2 to 5 millimeters, and if their pupils are super dilated and abnormal, it would be above 6 millimeters. So then next, I will be checking for accommodation. So I'm going to ask my patient to go ahead and just look straight for me, and don't move their head, just move their eyes and follow my pen light, but while it's off. So I wouldn't have it on, I would just, move my pen light and have them follow it with their eyes. So I'm going to be moving in a whisker formation. So on this side, I'm going to go down, have them follow the pen light sideways, and then up, and then go ahead and do it on the other side. So ask them to still keep their head straight and just follow my pen light with their eyes. So go down, sideways, and then up. And then after that, Then I'll go ahead and inspect their nose, checking the overall condition, checking to see if they have deviated septum, if there's any blood or CSF fluid coming from their nose. And then next I'll be checking for their mouth, so if they have any dry, cracked lips, if it's moist, and then asking them to open their mouth, checking to see if their tongue's swollen, and then asking them to take a big, just to swallow for me, checking to make sure that they can swallow. So if they could swallow, that's good. Asking if they wear any dentures. And then also, since I'm close to the patient assessing this, I would also nonchalantly, not, telling my patient, but I would mentally assess for their breath odor. If they have like a fruity smell to their breath or not. That's also important. And then also I'm going to be inspecting the neck. So first I would inspect the neck, checking to see if they have any goiters, if their trachea is midline intact, and then also to see if they have any JVD on both sides. If not, then I could go ahead and assess for lymph nodes. So for lymph nodes, I'm going to go starting with preauricular, and then go to postauricular, then tonsillar, then submandibular, and then submental, and then go to occipital, and then move to superficial cervical, and then deep cervical, and then posterior cervical, which would be back here, and then also supraclavicular, which would be right here. And then for supraclavicular, if I do feel anything, it typically means that they have TB or if they have cancer. So with that, if there's no abnormalities present, then I can go ahead and ask if they have any, if they have, if they're having trouble smelling, if they having difficulty seeing, if they feel like they have blurred vision recently, just asking if there's any facial sensation abnormalities with them. If not, then I could go ahead and inspect the skin. So with the skin, what I would do is I'm going to be inspecting their upper extremities, inspecting to see if there's any skin breakdown, any skin integrity problems, inspecting the abdomen, seeing if there's any skin breakdown, and then checking to see if any abnormalities, even on the legs, inspecting to see, and also on the back. So then with this, along with that, I will also be checking to see the color of their skin, if they seem to be jaundiced, if they're flushed, if they're, if it's normal, checking to see if there's anything that just stands out of the normal. So then next I'm going to be checking for temperature. So for palpating for temperature, I'm going to be using the dorsal part of my hand, so going like that on their upper extremities, making sure, seeing if they're cool, clammy, if they're hot or dry, and also doing that to their lower extremities as well. So after doing that to their lower extremities, I'm then going to palpate for turgor. So for turgor, I'm going to go ahead and pinch on their clavicle and see if there's any tenting. If there's no tenting, then that means that they're hydrated, which is good. We don't want there to be any tenting present. Then I'm going to be moving on to my upper extremities. So for upper extremities, I'm going to be checking the range of motion of my patient's arms. So I'm going to ask them if they could go ahead and roll their shoulders for me, and then go ahead, close their eyes, and then hold out their arms. And then the purpose of this would be if there's any droop, because that could mean that they are a victim of having a stroke, And then next I'm going to ask them if they could go ahead and pull on my fingers, testing muscle strength. And then also if they have any pain in their upper extremities, like on their shoulders or anything, checking to see if there's any stiffness. And then if there is stiffness, then I go ahead and then push their arm back, seeing how far they can move their arm back, and then do it on both sides, testing bilaterally. And then with that, I'm going to make sure to check their fingernails, making sure that their nail beds are pink, and then seeing if there's any clubbing present. And I'm going to go ahead and palpate for any IV sites, any tenderness. If there's no tenderness, okay, then I could go ahead, palpate the radial, so palpating the radial, then the ulnar pulses, and then also the brachial pulses as well, bilaterally, checking for any deficit. And then also checking the pulses for capillary refall. If it's less than 2 seconds, that means that that's perfect. That's what we want for my patient. And then next we're going to be checking for capillary refill, and then after that I am done with my upper extremities. Then I'm going to move to my thorax region. So for my thorax region, I'm going to be assessing their chest cavity. So with this, I'll be checking for any bruising, any scarring, any abnormalities with their breathing, any use of like accessory muscles if they're having to bend over and breathe. And then I'm going to palpate their chest wall for any tenderness, seeing if they have any bulging masses, distension, any tenderness, any pain. And then I'm going to move on to auscultating heart sounds. So with heart sounds, I'm going to go ahead So for heart sounds, I'm going to go ahead and auscultate the aortic area, which is on the right side. And then I'm going to move on to the pulmonic, and then move on to the Erb's point, and then tricuspid, and then move on to the apical area, apical/mitral, which you would spend a minute on that region. So then after auscultating my heart sounds, then I'm going to note any abnormal findings if I find any, and then I'm going to go ahead and auscultate my lung sounds as well. So for lung sounds, I'm going to move from the left side, then across to my right side, go down, then across, then down, then across, then down and across, and then also check the lobes to the side, because that's where like the wings are, and then go to the other side. So once I've auscultated my lung sounds, I would of course do this if I was doing this on a patient, but of course I'm doing it on myself. But if I was doing it on a patient, then I would do it skin to skin contact, so that's easier to auscultate. And then next I'm going to ask them if they use any tobacco, if they if they're using oxygen, if they're on any oxygen, if they have a cough, if they have any respiratory conditions. And then if they answer no to all of those, or if they do answer yes to any one of those, then I would of course have to document that. And then next I would also assess their back region. So I would ask them if they're not in any pain and if they're perfectly capable of just scooting forward so that I could go ahead and inspect their back area. So I would inspect the position of the spine. So of course by inspecting, not palpating, so inspecting the spine, checking the back for any bruising, any skin tenderness, any breakdown, including the coccyx, because that's prone for skin injuries. And then also after I inspect it and I don't see any abnormalities, then I'll go ahead and palpate, asking them if there's any tenderness or if they feel any pain at all, so palpating. And then next I would also auscultate the posterior lung fields. So auscultating the lung fields, I would then go ahead and then start from the left side, making sure not to go over the bone. So I can't really do this on myself, but if I were to do this on a patient, making sure not to go over the bone, but starting on the left side, then the right side, then down the right side, and then across to the left side, and then down the left side, and then across to the right side, then down the right side, then across to the left side, then down the left side, then across to the right side, making sure to get all 8 bases on my back. And then next I would go ahead and inspect the abdomen region. So for the abdomen region, I'm going to inspect for any bulges, any masses, distension, anything that would seem out of the ordinary. So with that, then I'm going to go ahead and auscultate for bowel sounds. So for bowel sounds, since I already pretty much assessed earlier for my abdomen region, which I was checking for my thorax region, but then I also included in there my abdomen region. So since I already inspected my abdomen region, I'm going to start to auscultate my bowel sounds. So for bowel sounds, I'm going to go ahead. So for bowel sounds, it's going to be 4 quadrants. So I would start with my right lower quadrant, my right upper quadrant, my left upper quadrant, and then my left lower quadrant. Typically, you spend 5 minutes on each quadrant to hear your bowel sounds, whether they're hyper, hypo, or normal. And then after that, then I'm going to go ahead and percuss my abdominal regions. So after inspecting and after auscultating, then I'm going to go ahead and percuss. So for percussion, I'm going to go like this in my regions. Just like that. So that's how I would percuss. And next, I'm going to go ahead and palpate for any tenderness, any masses. And then I'm going to ask my patient if they feel like they're nauseous, if they feel like they have to vomit, if they have any difficulty eating, when was your last bowel movement, and is that typically normal for your bowel movements? Like, is it typically normal for you to go to the bathroom and take a number 2? Pretty much. So then next I'm going to ask them to go ahead and then just lay down and then just fold their, pull their feet up, and then making sure that I'm able to inspect their perineal area. So if they're like this on the bed, and then I'm going to go ahead and then put on my gloves so I can inspect it. And of course, since it's down there, perform hand hygiene before putting on my gloves, and then inspecting the perineal area. After inspecting the perineal area, I'm going to go ahead, dispose of my gloves, perform hand hygiene 20 seconds per CDC, and then ask if they have any pain with urinating, if there's any blood in their urine, if their urine seems to be a dark color, if they seem to notice an unusual odor in their urine lately, or if there's any burning sensation while they're urinating. If they say no to all of those, then I would then go ahead and move on to inspecting their lower extremities. So with their lower extremities, first I'm going to inspect to see if there's any, inspecting to see symmetry on both of their legs, and then seeing if there's anything wrong, if there's any abnormalities, and then also checking the range of motion. So for that, if they're able to walk and they're not fall risk, I would ask them to take a few steps for me just to see how their gait is. And then also, then next I would move on to inspecting after I inspected their legs for any skin breakdown, then I'm going to go ahead and inspect their calves for any pain, tenderness, or swelling, any edema. So then I'm going to go ahead and palpate their calves. So I'll palpate their calves like that, seeing if there's any edema, seeing if there's any edema. So then next, I'm going to inspect the feet, seeing if there's any skin breakdown, checking their nails on their on their toenails, and then also checking the capillary refill on both of their big toes, seeing if it's less than 2 seconds. And then after that, then I'm going to go ahead and palpate their dorsalis pedalis, or dorsalis pedis, I believe, and then where I would find that is on the top of their foot right here, but I would do it on both feet at the same time, checking it bilaterally. And then I would also check for their popliteal pulse, and then if necessary, post-tibial as well. And then after checking capillary refill in toes, hopefully that's 2 seconds and that's normal. And then ask them if they've had a history of falling in the past, if they use any crutches, or if they use a cane, if they use a walker, if they use any ambulatory devices to help them walk, because if they do, then they would be a fall risk. And then also, I would also have to do a Braden skin scale, adding this in also because I forgot to mention that when I was assessing the skin, but I would also do a Braden skin scale, and then also doing a fall risk as well. So then I would go ahead and ask them if they've had any suicidal thoughts, if they've thought about harming themselves, or if they've thought about harming others, and then ask them if they feel safe at home or if they feel safe here, making sure that they feel safe and that there's no history of abuse. And then next, I would go ahead and wash my hands 20 seconds per CDC, and ensure a safe environment for my patient by raising the bed to the lowest level, and giving them the call light, making sure that they know that if they need any more, if they have any questions, or if they need anything, that they could go ahead and contact me. So here's a call light. If you need anything, don't hesitate to reach out to me. And then making sure that the side rails are all the way up, and then informing my patient, I'm going to go ahead and document my findings, but if you need anything else, just let me know. So perform hand hygiene 20 seconds per CBC, and then walk out.